Hello, listeners. So we are going to talk on this slide about multiple sclerosis. And just as an introduction, one of my favorite goalies for the team I cheer for, hockey, happens to have multiple sclerosis. And so all the proceeds that are being made from advertisements on this video are going to be donated to the Multiple Sclerosis Association of America. So multiple sclerosis is a progressive demyelinating disease of the central nervous system. So it's going to affect white matter. Various clinical presentations can come in with multiple sclerosis, and there are also various clinical progressions. So no one multiple sclerosis patient necessarily presents the same as the other. Over 400,000 Americans live with multiple sclerosis, and over 2.1 million people have this disease worldwide. Prevalence is interesting. So there's a higher incidence in whites and Hispanics compared to blacks and Asians. The prevalence is higher in women compared to men, and there is a higher incidence in monozygotic twins. So you would think that there is a clear genetic corollary to this, which there is. But there is a higher prevalence in the U.S. North than in the U.S. South, even though the demographics are relatively similar. And besides that, if a person were to move to an endemic area, so let's say the Northeast or the Upper Midwest, from a lesser endemic area, let's say the Southeast, their risk of getting multiple sclerosis, of developing multiple sclerosis, goes up by 15 times. So there is an environmental trigger or an environmental some kind of environmental feed-in to multiple sclerosis, but we don't quite know what that is. But we do know that there is certainly a genetic component. So this is, again, this is the distribution of MS globally. So the high-risk areas include Canada, northern United States, central United States, also northern Europe, Russia. And then the lower risk areas include pretty much the rest of the world, with the exception of New Zealand and Southeast Australia. In the United States, the ratio of MS patients to non-MS patients is higher in the north and much lower in the south. So Washington, where I am in Minnesota, and in New Hampshire, or Vermont, are the most prevalent places for multiple sclerosis. Okay, so the history is going to be really important in patients who we are considering multiple sclerosis. So a lot of patients who come in with some kind of neurologic deficit, a lot of them will have a history of past focal neurologic deficits, but they were unaddressed, they didn't go in, they weren't documented, and subsequently they remitted without therapy, as a lot of multiple sclerosis defects do remit without therapy. However, it's worth remembering that MS tends to present in young, otherwise healthy people. So just because you have a healthy person coming in and saying that they have this deficit, you don't let it go away. Even if they've had it before and it went away, you don't not address that. You're going to address any kind of focal neurologic deficit, particularly in younger people, because those are the people we wouldn't expect it in. If it's an older person, we might think possibly a cryptogenic stroke, possibly the effect of an older stroke, but in a younger person, if they have a focal neurologic deficit, that's never normal. Even if it gets better, it's never normal to have that. So it's just worth remembering that MS tends to present in young, healthy adults. So anytime they come in with a focal neurologic deficit, multiple sclerosis is going to be high on our differential. The symptoms of patients who are having multiple sclerosis episodes or attacks, or if they have chronic multiple sclerosis, are weakness, they can be paresthesias. These can be either focal or they can be not corresponding to a particular single lesion. And that's kind of a sign that points towards MS, is when a patient has multiple neurologic symptoms and none of them really point towards a certain lesion. let's say you had a tumor on your spinal cord. That would point towards lateralized lesions or lateralized symptoms. But if you're having left and right symptoms and you're having some paresthesias and some weaknesses, but none of it really makes any sense with one single lesion in one part of the anatomic central nervous system, that points towards MS. MS often also presents with blurriness and diplopia, so diplopia just meaning double vision, and pain on eye movement, and that's known as optic neuritis. And you would see on an MRI, you would see inflammation of the optic nerve. On physical exam, you will see a patient with weakness, numbness, tingling. That's going to correspond to the areas they say are weak. And then they'll also have brisk reflexes. So the brisk reflexes are a result of the fact that multiple sclerosis is an upper motor neuron disorder. And in any patient with an upper motor neuron disorder, they're going to have brisk reflexes. If they have a lower motor neuron disorder, they're more likely to have lower reflexes or weaker reflexes. And then some patients with MS have gait disturbances, but that's going to be more in a more progressed case. So as far as diagnosis, there are lots of different ways that we can point towards an MS diagnosis, but the only real way that we can diagnose MS definitively is with an MRI. So you may have heard of getting vitamin levels, getting cerebral spinal fluid analyses, getting these evoked response potentials. Those are all good and those are all useful. But the MRI you have to get in order to make the diagnosis. So the other things can just sort of corroborate your diagnosis, but the MRI you need to get. And therefore, I would consider the MRI to be the best initial step. Certainly a laboratory workup is good, but as far as making the diagnosis of multiple sclerosis, the MRI is the best initial step. Other tests, as mentioned, include vitamin levels. So vitamin levels are good because one of the possible differentials could include subacute combined degeneration. So if you have numbness and tingling in your lower extremities, that can point towards vitamin B12 deficiency. So certainly, if you have a patient who is an alcoholic, you may want to get a B12 level before going ahead with the MRI. But certainly you don't need to get vitamin levels on a patient who's healthy and is having similar symptoms. Also, a lot of patients with multiple sclerosis tend to have low levels of vitamin D. Not all of them, though. Cerebral spinal fluid analysis is done sometimes, not so much anymore now that we've got better access to MRIs, but an oligoclonal band is seen on CSF analysis. And then the evoked response potential is just looking at the response of a nerve to a specific stimulus. So you may attach an electrode to check the response of the brain to a visual stimulus. In multiple sclerosis, because this is a demyelinating disease, that response is going to be delayed because myelin increases the speed of conduction. And so if you have demyelination, it's going to delay that process. But like I said, none of these, except for the MRI, diagnose MS. These are all just things that can corroborate your diagnosis. Now, different patients can have different progressions of MS. Most patients have the relapsing remitting form of MS, and certainly you can move from one to the other, so you don't always just have one form or the other. You can go from relapsing remitting to secondary progressive, and indeed a lot of patients do. But most patients, when their MS starts, they do have this relapsing remitting form of MS or pattern. So this is just a graph. You don't really make these graphs in the clinic, but this is just a graph to sort of imagine symptom severity over time. So relapsing remitting patients with MS, they are generally at baseline, normally healthy patients, but then they have these episodes where their symptoms become exacerbated. And so they'll require treatment for their acute symptoms, but then once their symptoms are treated, they go back to baseline. There are also patients who have secondary progressive. Now, a lot of patients who have secondary progressive originally had the relapsing remitting form of MS. And what happens is ultimately they hit a point for one reason or another, we don't really know, where their MS begins to get progressively worse, and with each individual exacerbation, they never really get right back to baseline. They just continue to get worse. Their baseline continues to get worse. There are some patients who from the get-go have progressive MS, so they're constantly getting worse. That's a minority of patients. And then there are some patients who from the get-go do have this progressive relapsing MS. So they're having basically what you have in secondary progressive MS, but they start with the relapses and they never go back to baseline. But what's most important to know is that the relapsing remitting form of MS is the most common, and ultimately it does go into the secondary progressive form in most patients. The differential for multiple sclerosis, as I mentioned, should include subacute combined degeneration, particularly in any patient who's malnourished or an alcoholic, and that's why it's always good to get a B12 level on the when you're differentiating multiple sclerosis, if the patient particularly has a history of alcoholism. Other things we might think about are spinal cord neoplasm, spinal cord AVM. So those are two things that affect the spinal cord. But in those diseases, there are two things. One, we're going to have constant symptoms. They're not going to get better. Two, they should lateralize to a particular side, and it should make anatomic sense that you have a lesion in this particular spot, and it's causing symptoms in a particular area that it corresponds to anatomically, neurologically. Also, cryptogenic stroke. So there are strokes that you can have that you don't really realize that you're having them because the symptoms aren't that severe. That can cause you to develop focal neurologic symptoms. And this is something to think about particularly in older patients who have risk factors for stroke, particularly hypertension. And the thing that's going to separate this from MS, again, is it's going to be in a more older patient, it's going to be sudden, and it's not going to remit. Usually the damage from stroke is relatively permanent. And then another thing to differentiate out is amyotrophic lateral sclerosis. Like MS, weakness is a feature of ALS. However, with ALS, it will be accompanied by muscular atrophy because ALS is a disorder of the lower motor neurons and the spine. So this will directly affect the muscle, whereas multiple sclerosis is a disease strictly of the upper motor neurons. Okay, so this is an MRI of multiple sclerosis. So what you see here are several lesions. These are T2 hyperintense lesions. And with MS, they tend to surround these aqueducts. So that's the good place to look for when you're looking, if you see a relatively normal MRI, if you're really hunting and picking for a lesion, the best place to start looking is around these aqueducts. So look around the ventricles first. These are obviously pretty big lesions. It's always going to be in the white matter. Sometimes you can have some gray matter atrophy long-term in the course of MS, but this is a disease of the white matter because what do you have? You have demyelination. So this is a disease of the white matter, and this is obviously very severe MS. Okay, so this is a little bit less distinct, but again, you see these lesions primarily surrounding the ventricles, the cerebral ventricles. Again, here's another rather severe case. I'm not so sure about the intensity here. I think this picture might be a little bad, but again, you see here a lesion right here. You see a couple right here, one here, and one here. Now, if you look at it sagittally, you see these lesions around the corpus callosum, around the ventricles, but they have this particular sort of elongated shape, and what these are called are Dawson's fingers, and they're sort of the pathognomonic feature of MS. So if you look at this sagittal section of an MRI, and you see these Dawson's fingers, that's MS. You can see lesions here and around the ventricle. There's another one. These are Dawson's fingers. These lesions, how they kind of point out towards the head. Here's another one. Okay, now you can also, on MRI, and you should be looking at the spine. And the spinal cord can also have lesions, and that can correspond to some of the peripheral symptoms, like symptoms in the arms and the legs that you might have. So you should also be looking for the lesions on the spinal cord. The spinal cord should be this nice gray color. Here you see this T2 hyperintense lesion. I'm not exactly sure what level this is. It looks like it's like I'd probably estimate based on these sizes like T8 or so. Plus you can see the ribs. So, but it doesn't really matter. As long as you see this lesion. Here's another one. These are a little bit less conspicuous. You see one or two here. This is at the level of the cervical spine, and then you see another one here at about C2-ish, right here. So those are spinal cord lesions. And you can definitely get those too, just like the brain lesions, anywhere where there's white matter. And then here is another one, and this is courtesy of Medscape, and they point them out for you right here. Okay, so once you've diagnosed a patient with MS and the MRI is practically diagnostic, the patient should be counseled of the nature of the disease. They should be educated about it. They should be told that it's progressive, but it can be controlled with medications. The symptoms can be controlled with medications. But ultimately, this is a progressive disease. They have to understand, you have to understand as the clinician, the patient's concerns. So answer any questions they have. A lot of times, if you're working in a tertiary care center or hospital, there will be particular social workers that know how to deal with patients with various illnesses, long-term illnesses like MS. You also have to stress the importance of overall wellness. There are a small section of people, and I'm sure we've all dealt with them, that once they get a diagnosis, a really devastating diagnosis like this, they kind of just let themselves go to hell, and you can't let that happen. So you have to stress the importance of overall wellness, that if they keep a healthy lifestyle, that's going to make dealing with their multiple sclerosis much, much better. There are a lot of people who have multiple sclerosis and are able to live very productive lives, including that first picture that I showed you at the very beginning, an all-star hockey player who continues to play in the NHL right now and subsequently has MS. So you can certainly be well while having MS. But you have to keep a healthy lifestyle like anybody else. So the most important thing to stress to your patients is to stop smoking. It has been shown that smoking is linked to a faster progression of MS. So any patient who has MS should be referred to a smoking cessation program. Weight control is also important because when you've got weakness, if you have to carry more burden of weight with you, then that's going to make your life a lot more difficult. And then a healthy diet, particularly including vitamin D. As far as medical treatment, there's a three-faceted approach to treating MS. One, we treat the acute exacerbations. So any patient is going to have exacerbations where their symptoms all of a sudden get worse. That happens in any form of MS. Two, we treat their progression. So all patients are progressing. MS is a progressive disease no matter what pattern you have. So there is always going to be a long-term therapy involved. So you'll always have this second one, treating the disease progression involved in the therapy of a patient with MS. And then you may need to treat complications, and those are just treated symptomatically. All right, so what do we do? First off, we treat the acute exacerbations if there are any. And a lot of times patients who have MS, who present with MS, are having an acute exacerbation, and that's what brought them in. So any acute disabling exacerbation should be treated immediately, and a lot of times that's going to require admission to the general wards, to the hospital, for a couple days to receive IV therapy with methylprednisolone. And this is just IV prednisone, but methylprednisolone is the IV form. So we treat them with that for 2 to 3 days, usually 3 days, and that's followed by a taper of PO prednisone for about a month. And the patient should have a significant response within the first couple days. So by the time they leave the hospital, they're usually good enough to go back to work. Okay, the second and most important thing is to treat the disease progression. So all patients diagnosed with MS have to be offered long-term disease-modifying therapy. You cannot be an MS patient and not be on treatment, or I mean, you really shouldn't. If you care about your health and your disease process. So the most common agent used today is interferon beta, and there's interferon beta 1A and interferon beta 1B, and they really just differ in their method of administration. Interferon beta 1B is administered subcutaneously, and interferon beta 1A is introduced intramuscularly. They have similar adverse effects, primarily the flu-like side effects. So achiness, possibly a little bit of fever, fatigue, nausea, malaise, and so forth. Another agent that's commonly used is glatiramer. This is a newer agent, and it's particularly noted for its relative safety during pregnancy. Now, I say that relatively because all agents are technically contraindicated during pregnancy. But glatiramer is characterized as pregnancy class B. So it is the safest MS medication that we have. There are newer drugs, including natalizumab and fingolimod. Those both have some significant adverse effects, and so we tend to use those more as second-line agents if interferon and glatiramer both are either not satisfactory to the patient or the patient is not responding to them. So natalizumab is also known as Tysabri, and the problem with this medication is that it can cause PML, which is progressive multifocal leukoencephalopathy. So before we start patients on natalizumab, we try to see if they have the JC virus. With fingolimod, it can worsen complications of diabetes mellitus, and it can also cause macular edema. So before giving a patient this, we have to do a workup, ophthalmologic workup, and we also have to get an EKG because fingolimod can, it does shorten the heart rate, and it can cause PR prolongation. So we don't want to administer fingolimod to any patient that has heart issues. The one upside to fingolimod is that it's oral. So it's easier for people to take on a daily basis. They don't have to deal with needles or anything. But for the USMLE, the right answer is going to be interferon beta 1 or maybe glatiramer. You probably won't need to know about these drugs for the USMLE. Okay, then the third thing is to treat various symptoms supportively. So a lot of patients with MS, because they have upper motor neuron disorder, have spasticity. And so we can treat them with muscle relaxants, notably baclofen and dantrolene. We can also give them diazepam, but diazepam, being a benzodiazepine, creates a great deal of sedation. So if you're going to use that, then use that for nighttime use. For fatigue and narcolepsy, a lot of patients with MS have fatigue. You can use amantadine, you can use modafinil, and if it's really serious, you can use methylphenidate, which is Ritalin. For pain, you can use, and a lot of patients who have MS, where their pain originates, where it is most of the time, is trigeminal. So a lot of them have trigeminal neuralgia. You can give them phenytoin, carbamazepine, or pregabalin. And then for urinary urgency, You can use just the same things that you would use in an older woman with stress urinary incontinence. So tolterodine or oxybutynin. And this is just kind of summing up therapy for multiple sclerosis. There were a few that we didn't talk about, ones that are rarely used, sort of our third-line therapies for multiple sclerosis. Mitoxantrone carries a black box warning. It can cause cardiotoxicity and acute AML. I suppose acute AML is probably a redundancy. Acute myelogenous leukemia. And then cyclophosphamide and azathioprine, they're very, very rarely used, and if they are, they're used in conjunction. Cross those out as far as right answers on the USMLE. You will never use those on the USMLE. For the USMLE, it's interferon beta or glatiramer. Long-term management. Of course, it's important to have regular follow-up with patients with MS, probably at least once every 6 months. Usually they're going to be seeing a neurologist who specializes in MS. At the commencement of interferon beta or glatiramer therapy, usually when the patient has first been diagnosed with MS, you should follow up at 6 months after you've started the treatment to ensure that no more white matter lesions are present on the MRI than were present on the initial MRI. And if there are any more white matter lesions, present, then you should consider switching to a different drug. So if they're on interferon, you should consider switching to glatiramer or vice versa. Ancillary care, as mentioned, is very useful. So these patients certainly can benefit from occupational therapy, speech therapy, physical therapy, psychotherapy for any kind of depression or anxiety that might surround their illness, a social worker to help them with employment if they need particular employment with their disabilities, and so forth. And it's absolutely mandatory, I'm going to end here, absolutely mandatory to stress smoking cessation. MS patients who smoke are in a lot more of a damned position than MS patients who don't smoke. Apart from the fact that smoking causes lung cancer, COPD, and all that other great stuff. So that is the end of MS.